Hey there, and welcome to Concierge Medicine Radio, your source for actionable advice and real stories of physicians running and growing concierge practices. For more interviews and notes on today's show, please visit conciergemedicineradio.com and enter your email. Now, let's join your host, Taylor Pearson.
Hey there, and welcome back to another episode of Concierge Medicine Radio. Today I sit down and talk with Dr. Ernest Brown, based out of Washington, D.C. Ernest runs a house call concierge practice that he launched straight out of residency, and he has built a network in his local community and created a unique practice model entirely based on house calls that he finds more fulfilling than practicing in a traditional clinic. So we talk a little bit about how to evaluate your city to see if it would be a good fit for a house call model, how to set up a cash-only house call practice, why Dr. Brown finds house calls more rewarding than working in a clinic, and also an interesting opportunity to use house calls as a way to build a cost-effective concierge or direct pay clinic. So without any further ado, let's get on with the show. So, who are you and what do you do?
Yes, hi, this is Dr. Brown. I'm a house call physician here in Washington, D.C. Been practicing house calls for the past 8 years, providing it as a family physician in Washington, D.C. to travelers, VIPs, business professionals, and residents.
And tell us, how did you get into house calls? Give us just a little bit of context and background from how this kind of evolved out of your residency and your practice after that.
I took an interest in house calls purely by accident. It started when I was a medical student and I was rounding with a physician during rotations, and that physician walked into a patient's room, and it was an elderly woman, and she had the best bedside manner I'd ever seen, and he sat down on the bed, he held Mary's hand and said, "Mary, I think you're doing great. Let's get you back home, and I'll see you at home in a week." And that one statement changed my entire career, because I originally thought I was going to be an emergency medicine physician. That was the pace and everything. It excited me. But that one statement really kind of shocked me, because, I was like, what do you mean you're going to see her at home? How are you going to do that? And the other part was, it really touched into how devoted this physician was to his patient, a connection that, in a hospital environment, you just don't find. And I was so intrigued by it that I asked the physician, and I said, "Look, I think it's great that Mary's going home, but I heard you're going to go see her at home. What do you mean?" And his whole face lit up, and he smiled, and he said, "Well, that's all I do. I'm a house call physician." I was just, amazed that I actually found a house call physician, and the fact that that's all he does. So I made the arrangements, and I was riding around the streets of D.C. with this attending, picking his brain and, just enjoying the experience of being out in the community. And that really set the tone for, the rest of my career and my mission as a physician.
And you're a direct pay house call physician, right?
That's correct.
So tell us a little bit about how your practice is set up. Maybe start us with what an average day looks like for you. And I know that's probably a hard question to answer, but just to give some idea. And then also just kind of like the economics and business model of the practice.
Yeah. So the house call services I provide obviously are fee for service. And I get a lot of questions from consumers when a call is made. What's this going to cost? So part of it is knowing enough about, what the value of the service that's provided. I simply explain to them, or I try to get more information from them about their insurance. I try to explain to them, look, your insurance, you can submit the documentation that I provide, and they'll provide you a compensation that's appropriate, whether it's a PPO or some other insurance policy that pays a percentage. And, but I stress to them, it's a matter of, what you need right now, the convenience, not having the hassle, not having, the impersonal approach to them getting better again. My typical day starts, I wake up in the morning and I do my usual routine, try to do a little exercise, eat, and I'll get a call that comes in. The calls that I get, they're not scheduled. When they come in, I make myself available. And, I may only see 4 or 5 patients a day. And when those calls come in, I, first of all, always introduce, why have they called? What's the medical need? Even before there's any discussion about what the cost is. Because I need the patient to believe in the therapeutic value of the relationship. And by finding out what's troubling them, what's really the problem, I'm able to get them engaged and demonstrate that I'm there to help. And once it's determined that a house call is necessary, I make the arrangements. All of my practice, it is fully mobile. My vehicle is my clinic. I go to wherever the patient may be. That may be at a hotel, maybe at a law firm, maybe at a lobby office. It can be at an embassy. And it really just depends on what the needs are. And over the 8 years that I've been doing this here in Washington, D.C., the community knows that I'm a resource. And I value that. I value being part of my community and knowing that people can call me. And it's reflected back on the support that I've got. The days can be sometimes long, I'll be honest, but there's a lot of flexibility. I have an 11-year-old son. I'm able to carve out time for him for the critical periods. I'm not stuck set schedule. For instance, my son was sick recently and for 3 weeks, and if I didn't have that flexibility, I would not have been able to be there without having to take some kind of family medical leave. So a day can progress. Some days they may be lighter, and when they're lighter, I'm working on other projects. And when they're heavier, I'm going full steam. And it really is important to understand that, you make it what you want it to be, as opposed to it's made for you and you have to fit in that. So it's as much as you want to do or as little as what you want to do. For myself, I've been loving it since I've been doing it.
And when you say you can carve out time, do you turn your phone off and just make yourself unavailable for certain periods of the day or certain times?
In general, the call volume isn't that high. It's not like my phone is off the hook.
Okay.
But, I do keep it on because one of the caveats is that there's a reason why somebody's calling. It could be a property. It could be a resident. They want some help. And from my own personal perspective, I like to be there. And so I do keep it on. And I always tell people, I am available. Just call me. And if I can't get there right then, we'll work something out for when I can get there. And look, that's certainly been the case for the last 8 years. And it fits well for me. It may not fit well for others, but it's really how you structure it. I think there's certainly opportunities where you could say you're going to be on a certain schedule and make people aware of it. Because obviously if somebody calls and they're just getting a voicemail, that can be rather dissatisfying.
Well, I want to come back to kind of your patients, how they find you, and how that aspect of the practice works. But give us a little background on your pricing structure. How do you send invoices? How does the whole business of being a direct pay house call physician work?
So once the care has been provided, that's when I have a discussion with the patient that, look, I'm not here to just diagnose and treat you. I'm here to follow you until you get better. And there's value in that. And so the actual final invoicing doesn't come. It's all combined in a medical report, combined invoice. And it's all itemized. And, patients can pay by credit card. That transaction occurs after, my last visit. And the pricing structure, it depends on the level of complexity. I like to be able to put it at a certain dollar amount for the visit itself, but then there are additional things. So an average visit will be anywhere from $300 to $400, and then it depends upon what other itemized fees there might be. For instance, if a patient needs an IV, I'll do an IV, and that has certain associated costs. I have to factor in supplies and time to be there for the IV treatment, injections, costs for medications. I do carry a significant amount of medications, obviously no narcotics, but all the standard antibiotics and things, to be able to cover and treat patients as quickly as possible. So if they're sick, they don't have to go to the pharmacy. Yeah, and any other supplies that are necessary. I mean, my car's not packed to the gills. I basically have a black bag and medicine bag, and that's it.
Right. So do you have just a price list you've developed for what it costs you to deliver each of those services?
We don't have a menu price list because some cases are more complex. Some of them are very straightforward. So I would say $400 for everything. But, you're talking about after hours, weekends, those sorts of things, and how that rate changes. Is it a holiday weekend? Is it, 3 o'clock in the morning, which I don't get that many calls at 3 o'clock in the morning, but if it is, I can't charge the same amount that I would say for 8 p.m. after hours charge. I try to be as upfront with patients before ever agreeing to do the house call, and that's appreciated, but I'm able to garner more value for the service I provide, not only for just going out, but the follow-up. And I very rarely have issues with regards to cost. And when I do, it's mostly because people who have domestic insurance and their fear that their insurance won't pay them back enough, which is a reasonable fear. But to answer your question more specifically, there is no set fees. It's really dependent on what the care that's delivered. And another important point is you have to think about the market in which you're in. Obviously, Washington, D.C. is going to be different from Miami, from New York, or Boston, or any other area. And another consideration for that is the area that you're in is how do you structure your practice so that you are getting enough of a volume so that you can do it full time. I think that having a practice that's only mobile house calls works for me. May not work in other areas where it may be either logistically more difficult or the market itself doesn't reflect well for just a full-time house call practice.
So let's dive into that. What are the demographics of your patients and the logistics of Washington, D.C. that you think makes this practice viable?
In Washington, D.C., the services provided to hotels, embassies, businesses. We do a significant portion of travelers, and those travelers have travel insurance. When we look at the visits themselves, tend to be more sick visits. These are not continuity. These are not chronic care patients. And so it is a one-time visit and follow-up. And, the numbers that are residential are lower, but there certainly is more of an interest in going into promotion to domestic residential clients as well. And we do have some, but we try to keep it mostly geared towards those who are traveling, don't know the healthcare system, need to get care quickly, and then move on.
If you had to guess in terms of the split between residential and people that are transient or travelers, what do you think the split up is?
I'd say about 75% is traveler,
Okay.
and the other 25% would be residential, business as well.
So how do these patients find out about you? You're coming to Washington, D.C., you get sick. How does someone know to call you?
I am known in the community. I'm born and raised in Washington, D.C. I've got friends almost everywhere, and it is majority word of mouth. We have certainly through the hotels, concierge, and the concierges across the city are like family to me. They, know that they can call me, and I will take care of their guests. And I can get a call from a concierge, I can get it from an office manager, and it really is that, I don't have a billboard, I don't have my own personal website. It really is, I'm here and people know that I'm here to help.
So walk us through, if you were listening to this interview and this was something that was interesting to you, the house calls were appealing, how would someone start this practice? What would kind of be like the first steps to see, is the area I'm living in viable? And then if it is, how do I get it off the ground?
Yeah. No, the first thing has to be the market. You have to get a sense, like if you were doing Washington, D.C., you have to look at, well, how many hotels are in a certain area? And for myself, I live in an area that I can get to most of those properties quickly. If you're in a suburban or rural area, it really, you can have volume, but then you have to shift to more residential. And you're not going to have as many travelers. And you have to be able to have some point of access. Where are you going to be able to market your services? For myself, I don't market as much because I just don't have to. But for those who are trying, and I've seen others who have tried, do need to have a web presence. You do need to get your search engine optimization so that people can find you. You do need to reach out to the local media, or if you have a PR person. And it does take time. It's not going to translate overnight. But that's the same for brick and mortar. It takes time to build up a steady population of patients. But if you stick with it, I think you'll find that, the compensation for your time, the value, and the relationships are invaluable.
Well, tell us how you built it up. Like, what specifically, I guess, about Washington, D.C. makes it viable? Do you think this is only viable in an area like D.C. that's got so many transient or travelers coming through? Or could it be somewhere, Tulsa, Oklahoma? Would it be viable there?
So part of it is DC is a good place for what I do. I don't think for myself it would be entirely easy to pick up and move someplace else. I could do it in a major urban population area. It would be harder logistically in an area that's more suburban or rural, simply because of the travel time. That's a killer. There's no question. House calls, you have to be able to plan it out right. If you're driving most of your time, then, first of all, I don't recommend traveling more than an hour to be able to do a house call. It's just not logistically reasonable. And then, for DC, we do have a lot of travelers, and, so that certainly keeps it sustainable. But if I didn't have that market, there is a tremendous demand on the residential end. And that I don't like to overburden myself with the work that I do. I like to know that, I can provide care and it works for the travelers, and so I have less residential. But I certainly believe countless times when I talk to residents is I can't believe this service exists. And you have to have them understand the value of the service. For myself, that was a thought I had 5 years ago when I was looking at leaving insurance and behind and really, well, what is the value of the service I provide? And that only came when I was living in a house in Washington, D.C., and a leak developed at 10 o'clock at night. And I thought, oh gosh, what am I going to do? So I called a plumber out. Obviously, I woke him up, and he was a little groggy, but he said, okay, I'll be there in about half an hour. Got to the property, spent about half an hour, fixed it, and gave me the bill. And the bill came to $1,200. And at first I was like, wow, this seems rather high. And, I was kind of taken back that it would cost that much for a half hour for, sure, I got him up late. But his point was, well, yeah, the value of the service is that your floors are not rotting and, you haven't destructured the structure of the home. What value is that to you? And I kept that interaction and that thought. And to this day, I'm constantly questioning what is the value of it. I had a friend who had a colleague in town and was a keynote speaker at a presentation. And she wasn't feeling well. So my friend asked me to go out. And I talked to her before going out and to determine a little bit more about what I could do. And I said, well, I could be there in about 15 minutes. And she said, that's great. How much? I said, well, it sounds like this will probably be about $400. And she said, my God, that's ridiculous. And I said, well, you're a friend of a friend, so I can do it as a courtesy. And I got out there, and, she was a keynote speaker, and she was preparing for her meetings. And I provided the care, provided the medications, the diagnostic testing in the room. And, she got better that night and was able to meet her presentation the next day. And when I followed her, she said, I can't thank you enough. You saved my entire trip. I've been planning for this presentation, all the travel and everything. And, thank you so much. And I said, well, what was the value of the service I provided? And, she commented, and I said, well, look, I've got other friends, the veterinarians, who make 3 times more than I do. But, was the value of it? And she said, that's funny you mention that because I just took my 2 dogs and each one cost me $3,000.
Yeah.
And, it was just kind of like, okay, all right. So, I think the problem that exists right now is this idea of value. And I think the situation we're in right now is that the public, patients in general, just really don't comprehend what the value is. When they pay a $20 copay, they think that's all they're paying. But you and I know that's vastly different. They pay a lot more.
Yeah, all the costs are hidden,
yeah,
and they're opaque.
Yeah. And so by that token, part of the problem is people just don't know what they can kind of get the value, what the associated value would be.
Yeah, it's interesting. I run into that problem all the time with clients and trying to, the term I use is value-based pricing. Like you want to price something where it's a good value for the end consumer, whoever you're providing the service for. But it's so tricky to make that tangible, and explain exactly what the value is. Like there's definitely a big education process to overcome there. And I mean, I think I see this with a lot of physicians that email me or I talk with trying to educate patients. The patients are so used to that copay model and they don't associate all the money they're spending on, say, like a low deductible plan where they have very high premiums with a doctor's visit. They've got those in like two separate buckets
Yeah.
in their mind, and you have to explain them. And I think there's a lot of good analogies, like the car insurance analogy is one I hear people use a lot. If you used your car insurance to pay for gas, you could only go to certain gas stations. You'd have to get pre-authorized before you left town. And people sort of start to understand why that model doesn't work. But there's definitely a big education hurdle to get over there.
Yeah, absolutely. And, it is our responsibility. Patients are our best advocates, but we do have a responsibility to educate them. And, there's a lot to that. And, one of the things for my residential clients, I always say, look, I understand you're going to submit this in insurance. Maybe you'll get 68% back, and you value the service that I provide coming to you and following you. But if you're concerned about the price, then look at thinking that you might get sick once or twice a year. Put that aside on a HFA or HSA, and then you have that security that, look, you can call on me and I'll come out. And so I've certainly had residents here who've done that. And then it's not even an issue.
And to come back to the earlier question about figuring out where this practice might be viable, what I'm kind of taking away from all this is you're looking for probably a fairly dense urban area where you can build some contacts with. It sounds like mainly hotel concierge, and you said office, some sort of office staff. Is that like in the embassies?
Yeah, well, businesses.
Okay.
We'll have businesses, medium-sized businesses that, we have a lot of law firms and lobby groups here in D.C. Time is critical. They need.
Okay, so they're willing to, they see the value in it because obviously instead of having someone take a day off to go to the doctor, you can come into the office and take care of them.
Yeah, so, I do work with human resources.
Okay.
At a number of businesses, they call me in.
And how did you build those contacts? Was that just
really
friends of friends, or did you?
It really was reaching out. There are different associations, different groups. In Washington, D.C., we have a Concierge Association. There's Property Management Association. There's Human Resources groups that meet up. There's a variety of different avenues to explore. And, to go full time.
Do you have any specific examples of groups you talked with or how you approached them?
Well, the Concierge, it really was just becoming a member and going and getting to know them, and over the years, developing the relationship. And quite honestly, my meetings that I go to for the Concierge are fun. I go to CME meetings, and it's rather depressing, but they're fun to interact with the concierge, and they're very knowledgeable and so forth. But, even the human resources groups, there are always property management group meetings and things like that. And you'll be surprised at how people will just, like magnetism, they'll be attracted to you.
And how long did it take to get the practice off the ground from when you decided you wanted to do this? What was kind of the path to making it a viable full-time thing for you?
It took less than a year.
Okay. So pretty quick.
And, again, that's my market, so it certainly can be very different. And, I certainly welcome the opportunity to talk to physicians who more guidance or, brainstorming.
Well, do you think there's an opportunity, and I've talked to a couple people that are doing this. One is pediatrician and the other's a family physician that are using house calls to get direct care or concierge practices started. Mm-hmm. And then eventually moving into an office. Do you know anyone that's doing that?
Not in the D.C. area. I have heard of some who are doing it. The advantage of doing the house calls and starting that off first is you have no overhead. And,
yeah, the overhead is just zero.
Zero. It's you and the patient. And if, you do need to grow that, myself personally, the idea of sitting in a clinic, bothers me because I can't do it again. This is what I do. It's everything. And I'm successful at it. And, I think, physicians, it all depends on your life choices. But I think moving back into clinic can be hard after you've done house calls. That's why I don't, for certain practices, I don't think a blended practice is viable. Obviously, if you have 2 or 3 physicians and schedule it right, maybe you could.
And blended, you mean house calls and clinic?
Yeah.
Yeah. Well, I guess it's appealing to me or interesting to me because my background is sort of the bootstrapped startup movement. And so anytime you can keep overhead and expenses low, it just buys you more time to figure everything out, especially when, you're stepping into a new venture and there's not a really clear roadmap forward. The lower you can keep your overhead and expenses,
Yeah.
the more time you have to figure out what that roadmap looks like and what you want to do.
Yeah. And look, physicians used to do this. We used to live in the areas where we served, and we were the doc down the street, brought his buck bag, took care of Johnny. We moved away from that. We got into brick and mortar. Patients came to us. We don't even live anywhere near where we actually practice. You engage the community, and it will come to you. I mean, it's surprising. It will come to you. They'll respect what you do. They'll come to you for care. And that's very rewarding to me. Being born and raised in Washington, D.C., I love this city. And what really makes it meaningful for me is, look, I can walk down the street and pass by a restaurant and they'll, hey, Dr. Brown, and, invite me in to have dinner for free. It's just one of those things. It's nice to be appreciated, and there's value in that.
And to be seen, as a valuable member of the community just because you're so out there.
I think we lost that. Certainly the relationships with patients is vastly different than they were in the past. My older physicians who are my mentors, they lament on that their practices are just churning patients through and they don't even know anything about the patient anymore.
Well, tell us some of the mistakes you've made. Looking back since you've started doing house calls, what are some of the things you wish you hadn't had to find out the hard way?
The hard way was trying to work in that blended practice model.
Okay.
Where there was a clinic, and that was before I went off independent, where there was a clinic and they had a set schedule, and you had an office administrator saying that, okay, well, you have to see 8 patients a day, and then they would handle the schedule, and they would send me all over the city, and no rhyme or reason to it. And they didn't know the patients. They just knew, this patient needs to be seen and so on and so forth. The other part was the communication piece. The patients had to call the office, not me. And so they would call the office and there would be a problem and I wouldn't know about it and I'm already out and seeing patients. So hard for me to be able to manage that. By taking away those barriers, and which was a leap, but taking away those barriers to patients brought it all into my own control. I have a better pulse on things. And, that blended practice, trying to have a clinic and house calls, that was what troubled me for years before I started running the clinic.
And were you doing urgent care or emergency room kind of in that transition period when you were building up the house call practice?
So after training, I knew what my mission was. My mission was house calls. All I've ever done since training was house calls. The thought of urgent care and those things, it's just, I know for myself personally, I would be hugely unsatisfied. And it's not, could I make more money in an urgent care? Possibly. But I don't see how I fit. For me, right here, right now, this makes sense.
Well, yeah, I think it's interesting to bring these different models to the table and see. I think a lot of it is just personality types from different physicians I've talked to, what they feel comfortable with, and both in terms of lifestyle and risk and what they find fulfilling and rewarding. There's kind of lots of different ways to approach it.
Yeah, and you have to explore it. Don't give up on it easily. It does take time, and I know people will have some concerns. Safety. If you're a female physician who's going out and how can you make sure that you're safe? I always have it so that if I'm being a male, I always make sure that there's some form of security always available close at hand. My vehicle is labeled. Anybody who's a residential client, I require a family member to take me from the car to the home and invite me into their home, essentially. Any property, if it's a business that, they have somebody from human resources there, or if it's a hotel, that they have security available. There are all these things, but the best thing is to get started and work and think about it in the way that's best for yourself.
Well, if someone wants to get in touch with you, find out more about your practice and what you do, what's the best way to do that?
Best way is shoot me an email or just give me a call. And, if I can't answer the phone, I'm with the patient, but I'm happy to talk to others.
And do you have a good email to reach you at?
Yeah, good email is doctor, spelled Dr. Ernest, which is my first name, like Hemingway, Ernest, Brown, like the color, at gmail.com.
Okay, and we will, I'll get your phone number up on the site as well as your email. So if people want to get in touch with you, they can go to conciergemedicineradio.com and this will be on your show notes.
Okay.
Well, Dr. Brown, it's been a pleasure chatting with you. Everyone else, thanks for joining us, and we'll see you next week.
Absolutely. Thanks so much.
Cheers. You can go to conciergemedicineradio.com to get this episode's notes and links to everything we've talked about, as well as the entire back catalog. For those of you working on bringing in new patients or retaining existing patients in your direct pay or concierge practices, we've also got a new report on the 5 keys to marketing for direct pay and concierge physicians. After asking physicians across the country about their biggest problem, I kept hearing the same thing come up. Patient education and marketing. How do we help patients understand what we do? So I put this report together after interviewing dozens of the most successful concierge and direct pay physicians across the country for the stories and tactics on how they've been able to generate dozens of word-of-mouth referrals each month, find more new patients through speaking opportunities, get featured in their local press, and use their website and online presence to educate their patients and grow their practice. So if you'd like to read their stories and see how to use them to help grow and retain more patients in your practice, you can download that on our site. Talk to you next Tuesday morning.
Thanks for joining us today at Concierge Medicine Radio. If you found today's show valuable, we'd love it if you spread the word by leaving us a review on iTunes or sharing it with your friends. To see notes on today's show, please visit us at conciergemedicineradio.com. While you're there, leave us your email to hear about all upcoming episodes.